Under massive weight, a complex structure's threads rarely snap at once. Instead, they stretch, vibrate under tension, and slowly pull the system out of alignment. In the NHS, musculoskeletal, or MSK, conditions represent a primary driver of elective care demand. These issues involving joints, bones, and muscles create a massive, compounding pressure on the healthcare system's capacity. While medical complexity is a factor, much of this systemic tension stems from a phenomenon known as decisional conflict. This occurs when patients walk into a consultation without a clear understanding of their condition or the specific treatment options available to them. The clinical fallout is measurable. Without a clear map, patients face deep uncertainty, leading to delayed decisions, repeat wait-and-see consultations, and variation in the care they eventually receive. Patient indecision is a byproduct of a fragmented pathway, a structural friction point that directly compounds waiting list paralysis. The standard approach to shared decision-making, or SDM, relies on providing patients with free information pamphlets or digital aids. SDM is the collaborative process where clinicians and patients weigh treatment options together. These tools are almost exclusively deployed outside of the actual clinical consultation. Patients are expected to interpret complex medical information on their own, away from the clinician. By pushing the decision-making process out of the room, patients frequently feel forced to navigate binary choices, most often perceiving their path as either intensive surgery or doing nothing at all. Torbay Charts offers a different model. It is a commercial, structured decision support approach designed to be used by the clinician and patient together, inside the consultation room. For system commissioners, this introduces a specific question of value. Is the disruption of clinical workflow and the cost of training for a 22-minute consultation tool a justifiable investment? A multi-site service evaluation sought to answer this, tracking the approach across 5 different healthcare settings with 202 patients and 55 clinicians. Replacing the traditional data dump with a visual pathway, this flowchart aligns treatment options to the disease stage across 3 zones: self-management, non-operative, and surgery. The layered structure allows a high-level overview while enabling a deep dive into specific local services. Feedback from the clinicians involved indicated that this structured dialogue remains time-neutral. It fits within a standard 22-minute consultation, addressing the primary operational fear of clinical leads. This aligns with findings from the University of Bristol, which suggest that shared decision-making tools only survive in routine practice if they possess high usability and can be integrated into existing workflows. The success of the tool depends on its ability to organize the clinical conversation without fighting the existing operational clock. Visual structuring facilitates cognitive offloading. This process reduces the mental burden on the patient, making it easier to process high-stakes information in real time. The evaluation established a pre-consultation baseline, where approximately 50% of patients entered the room unsure of their treatment decision. This chart shows the change in uncertainty. We start at 50%, but post-consultation, the proportion of patients reporting indecision drops to just 9%. This 81% reduction corresponds with a direct shift in how patients selected their treatment pathways. Specifically, 15 out of the 202 patients who initially anticipated surgical management chose non-operative options once they had used a structured visual aid. For these 15 individuals, a clearer understanding of the pathway led to a voluntary shift toward lower-intensity care, demonstrating how informed choice can influence referral volumes. System commissioners are increasingly focused on GIRFT compliance, getting it right first time, a national program aimed at improving clinical quality and efficiency by reducing unwarranted variation. The observed 7.4% behavioral shift provides the necessary basis for indicative financial modeling regarding system-wide cost avoidance. This scorecard illustrates the potential impact. Applied to a standard cohort of 2,000 patients, the modeled cost avoidance exceeds £1.15 million annually. This £1.15 million figure is a conservative estimate, as it accounts only for the direct procedural costs of the avoided surgeries. It excludes other benefits, like fewer repeat consultations and improved pathway flow. Standardizing decision navigation at the first appointment provides a mechanism for hospital trusts to create financial and capacity headroom. A rigorous look at the data requires acknowledging that this evaluation was observational in nature. The methodology lacked a control group and relied on patient-reported measures, which are subjective rather than long-term clinical tracking. Consequently, these findings should be treated as hypothesis-generating regarding long-term clinical outcomes and cost implications. However, the framework has been in routine, sustained use at Torbay Hospital for over 6 years, providing an operational proof of concept that supplements the academic data. While long-term randomized economic proof is still pending, the framework's ability to survive in a real-world clinical environment is established. The impact of the Torbay charts can be categorized into 3 specific areas: patient experience, workforce empowerment, and system efficiency. Patient experience is improved through clearer understanding and the end of binary treatment choices. The workforce is empowered by a standardized navigation approach that respects the constraints of the 22-minute clinical clock. Finally, system impact is achieved through cost avoidance and by reserving specialist surgical time for the most appropriate cases. Raw information rarely changes behavior on its own, but when the clinical dialogue is structured to help patients make clearer decisions, the entire healthcare system can operate more efficiently.